Okay, our next speaker is Dr. Kothari. She's an assistant professor of medicine and the associate director of endoscopy at the University of Rochester. Her clinical and endoscopic interests include interventional EUS, pancreatic biliary disorders, and Barrett's. She's unfortunately unwell, but has been gracious enough to do a virtual lecture, so we really appreciate it, and we're sad she's not here in person.
Good morning, everyone. I'm Shivangi Kothari from the University of Rochester. I would like to thank the course directors for giving me the opportunity and for inviting me to the course. Sorry, I can't be there in person, but looking forward to a great discussion later today and hopefully to see everyone soon in person. Today, I will be speaking on pancreas cysts, understanding the guidelines. I will be talking about the various types of pancreatic cysts, review the guidelines that are out there for the surveillance and management of pancreas cysts, go over the differences in the various guidelines and their overall impact in what we do for our patients. I will start off with a case of a 52-year-old male with history of end-stage renal disease on hemodialysis, hypertension, diabetes, non-Hodgkin's lymphoma in remission with last chemo over 20 years ago, and on immunosuppression for dermatomyositis, who presented for evaluation of an incidentally found pancreatic cyst. Oh, the cyst was entirely asymptomatic. He denied any weight loss or jaundice, and there was no family history of pancreatitis, pancreatic cancer, or other malignancies. So he had a CT without a contrast for another indication, and this was done for a pre-renal transplant evaluation and was compared to a PET scan that was done 10 years ago. And the CT revealed a dilation of his pancreatic duct in the head and body. And this was the official read, which showed a predominantly cystic dilation, and findings were significantly increased compared to his prior PET scan, where there was a 2 centimeter cystic lesion in the head of the pancreas, and the pancreatic duct was normal. So he did undergo an MRCP, which revealed again significant dilation of the pancreatic duct, as you can see on these imagings. And there is official reading was a dilation of the main PD to 1.2 centimeters and no significant interval change in multiple cystic lesions in the pancreatic head when compared to the prior CT. And the final suggestion was that there's a probably side branch IPMN with dilation of the main duct. And however, cystic adenocarcinoma could not be excluded, and an ERCP and/or EUS was recommended for further evaluation. And these were his labs. He didn't have any jaundice. CA 19-9 was normal. And I want you to keep this patient in your mind, and we will come back to it as we review the various guidelines and how we would apply them to this patient. So with our scans getting better, we are all seeing the tsunami of pancreas cysts with up to 3 million incidental pancreatic cysts diagnosed each year. And it is a very common incidental finding reported in up to 20% of CT scans and 40% of MRIs that are done for non-pancreatic indications. However, the reassuring part is about 99% are less than 2 centimeters, and about 0.25% of the cysts will be malignant at the time of diagnosis. And the risk of progression to malignancy in these cysts is about 0.24% per year. The risk of pancreatic cysts increases with age, with autopsy studies showing up to 25% of all pancreas would contain a cyst. And what this leads to is there is a rising surgical intervention seen over the past couple of years. And surgery in the pancreas for cysts is not without its own risks, with morbidity reported up to 64% and mortality between 1 to 7%. And finding these cysts in the pancreas, it leads to, of course, patient anxiety and anxiety in physicians with the various guidelines and the predictions being imperfect and what to do next for the patient. So our main concerns are when we see an incidental cyst, is this mucinous? Is it malignant or pre-malignant? Will this patient need surgery? What is the best way of working up the lesion? And does it matter that the cyst is not causing any symptoms? So just to give you a brief background about the pancreatic cyst, there are the benign cysts, which are your pseudocysts or your serous cyst adenomas, which do not require surveillance. And then there are the pre-malignant cysts or the mucinous cystic neoplasms, the side branch IPMNs, the main duct IPMNs, and the solid pseudopapillary tumors. And then the frank cancers, which could have cystic components such as a neuroendocrine tumor or adenocarcinomas. So in this table, you can see the various cysts and their features. And as I said, the serous cyst and the pseudocyst are your benign cysts. The serous cyst could have a classic honeycombed appearance, predominantly seen in females. Solid pseudopapillary tumors are mainly seen in females in their early 20s. They could have a mixed solid cystic component. And for cystic neuroendocrine tumors, they could have a peripheral rim enhancement. And for less than 2 centimeter cystic neuroendocrine tumors, the risk of malignancy is low. However, as they grow bigger than 2 centimeters, the risk increases. Surgical resection is classically recommended for all solid pseudopapillary tumors and cystic neuroendocrine tumors greater than 2 centimeters. Mucinous cysts are seen in mostly females between 40 to 60 years of age. These are mainly seen in the cyst. They do not communicate with the duct. And if you look at the fluid CEA and amylase levels, in mucinous cysts, the CEA is high, but the amylase is low. And again, as the cyst size increases, the risk of malignancy is higher. With the main duct IPMN, you see the classic PD dilation, and with IPMNs, you can see either just main duct involvement or side branch involvement, or there could be the mixed type. Again, the CEA is high in these levels. If it is side branch IPMN, the risk is variable depending on whether there are high risk features, and I will go over more of this detail as I review the guidelines. So as much as the CEA and cytology are routine tests that we do on the cysts when we FNA them, only 34% of cyst aspirates have adequate cellular material for any cytology evaluation. And neither cytology nor fluid CEA is perfect in deciding a mucinous versus a non-mucinous cyst. And of course, as we know, the only treatment is surgical, which has significant morbidity. And this is where the guidelines come into play to help guide us in what we would do for these patients and what would be the next best steps. Various guidelines have been published since 2006 that have attempted to provide diagnostic and therapeutic recommendations for mucinous cysts. Uh, the first guidelines were in 2006, which were the Sendai guidelines, and then they were revised and in 2012, and the revised Fukuoka guidelines have since then been revised and published in 2017. Also, the 2015, the AGA guidelines were published, and 2018, the ACG and the European guidelines were published. Prior to delving into the specifics of the guidelines, it is important to understand that the majority of these guidelines are exclusively discussing IPMNs and mucinous cystic neoplasms, because we did discuss that serous cysts and pseudocysts do not require surveillance. So before embarking on any surveillance for the pancreatic cyst, the main thing to understand for pancreatic cystic neoplasm is that if they have high risk features, you refer them to a pancreatic center. And if the cyst does not have any high risk features and the patient needs surveillance, the main thing to know is if the patient is willing to undergo surveillance, if the patient is a good surgical candidate, And if the cyst on surveillance does develop any high risk features, is the patient willing to undergo treatment? And if the answer to these questions is no, then you document the discussion, and these patients are not your ideal candidates for surveillance. And if the patient is willing to undergo the surveillance and follow through with the recommendations, and these are the patients that benefit with a surveillance program based on the various guidelines. So starting with the Fukuoka guidelines in 2012, the main thing that changed here that the classification of the precancerous cyst was no longer limited to just based on the size of the cyst or mean duct involvement, but also included were enhancing solid components in the cyst, and additional worrisome features were included, such as the cyst size enhancing walls, main duct size of 5 to 9 millimeters, and abrupt change in the caliber of the pancreatic duct. What changed between the 2012 and 2017 guidelines I've highlighted at the bottom is the surveillance of the cysts less than 1 centimeters, and cysts that were 1 to 2 centimeters without any worrisome features. However, one thing that remains consistent, as I discussed, was strongly consider surgery in young and fit patients, and cysts that were greater than 3 centimeters. And I will now come to the 2017 guidelines, and I've highlighted the changes between the 2012 and 17 guidelines. So criteria such as mural nodules greater than 5 millimeters were added as high-risk stigmata. And if the patients have the high-risk stigmata, then they are referred for surgical evaluation. And if the patient don't have the high-risk stigmata, then you evaluate for any worrisome features that are present on the imaging. And in addition to the 2012 guidelines worrisome features, what was added was presence of lymphadenopathy, increased serum CA19-9 levels, and cyst growth rate of greater than 5 millimeters per year. Since there are some studies reporting that if the cyst is growing at a rapid rate, then the risk of malignancy could be higher. And if the patients have those features, then you proceed with an endoscopic ultrasound. So, in the presence of worrisome features and EUS evidence of mural nodules greater than 5 millimeters, or evidence of changes in the main duct, or the presence of malignancy suspicious, or even malignant cytology, surgical resection should be considered. And if none of that is the case, then depending on the size of the uh, mucinous cyst, you either perform CT or MR or EUS at specific intervals. And here you can see in the 2017 guideline, for cysts less than 1 centimeter, CT or MRI is recommended in 6 months, and then every 2 years if no change is seen. And this is different from the prior guidelines. And for cysts that are 1 to 2 centimeters, CT or MRI is recommended for 6 months for the first year, and then yearly for 2 years, and then to lengthen up the interval up to 2 years. If the cyst is 2 to 3 centimeters, and any US is recommended in 3 to 6 months, and then lengthen the interval up to 1 year, and then alternating an MRI with an EUS. So, in similar to before, if the patient is young, surgically fit, then again, you refer these patients to a multidisciplinary discussion with the pancreas expert and the surgeons to closely survey them, follow them, and see if the patient is a good candidate for surgery. The AGA guidelines came out in 2015, and the AGA recommended again that before starting any pancreatic cyst surveillance program, patients should have a clear understanding of the risk and the benefits. The AGA suggested that patients with pancreatic cysts less than 3 centimeters without a solid component or dilated main pancreatic duct undergo an MRI for surveillance in 1 year, and then every 2 years for a total of 5 years if there is no change in the size of characteristics. For cysts with at least two high-risk features, such as size greater than 3 centimeters, a dilated main pancreatic duct, or the presence of an associated solid component, an EUS with FNA should be considered. The AG also suggested that patients without concerning results on EUS-FNA undergo MRI surveillance after 1 year and then every 2 years to ensure no change in the risk of malignancy. And if there is any changes noted in the characteristics of this cyst or development of a solid component or increasing size of the pancreatic duct or the cyst diameter greater than 3 centimeters, then you follow this up with an EUS-FNA. Also, patients with a solid component and dilated pancreatic duct and/or concerning features on EUS and FNA should undergo surgery to reduce the risk of mortality from an underlying cancer. The AGA guidelines are the first and only guidelines to recommend cessation of additional surveillance in the absence of changes in the pancreatic cystic neoplasm after 5 years of surveillance, or if the patient underwent surgical resection and a non-malignant IPMN was diagnosed. The ECG guidelines were published in 2018, and if you look at these guidelines, again, if there is any obstructive jaundice or a solid mass associated with the cyst, then the patient is supposed to be referred to a multidisciplinary group and consider EUS-FNA. Of course, if the cyst has classic appearance of a serous cyst adenoma or as a history of pancreatitis, and you're certain this is most likely a pseudocyst, then you follow them clinically. But if and again, you will see that MRI is the recommended choice for surveillance of between all these guidelines, because MRI is non-invasive. There is no radiation, has a greater accuracy in assessing the communication between the main duct and the cyst. The ECG guidelines again recommended that patients who are not medically fit for surgery should not undergo further evaluation of incidentally found pancreatic cysts, irrespective of their size. So, patients with IPMNs or mucinous cystic neoplasms with features such as jaundice or presence of a mural nodule or a solid component or acute pancreatitis secondary to a cyst with significantly elevated CA99, dilation of the main pancreatic duct greater than 5 millimeters, or a focal dilation of the pancreatic duct concerning for main duct IPMN or IPMNs or mucinous cysts greater than 3 centimeters. All these patients benefit with an EUS FNA for further characterization of the cyst. And if the cyst is low risk and does not have any of these high risk features, then they enter into the surveillance program based on their cyst size, which again I will go into a little more detail. So if it's less than 1 centimeter, they can get an MRI in 2 years. For 1 to 2 centimeters, MRI in 1 year. And for 2 to 3 centimeters, if the cyst is clearly an IPMN or a mucinous cyst, then you can do an MRI or a US in 6 to 12 months. And the main thing is that these patients are followed by a multidisciplinary pancreas team, including the surgeons, should the patient require a surgical intervention. The surgical resection is recommended for any mucinous cyst in a surgically fit patient in the 2017 International Consensus Guidelines. The 2018 European guidelines treat mucinous cysts similar to IPMNs, and that surgical resection is recommended for mucinous cysts greater than 4 centimeters if they are symptomatic or with the presence of high risk features such as a mural nodule, pancreatic duct dilation, cytology that is suspicious for or consistent with malignancy, and surveillance is recommended for all mucinous cysts less than 3 centimeters. The 2015 AGA guidelines and the 2018 ECG guidelines also treat mucinous cysts similar to IPMNs. So this is a little difference between the guidelines that I wanted to highlight in this slide. But the one thing that's common between the guidelines is that if the patient is symptomatic from the pancreatic cystic neoplasm, then surgical resection should be strongly considered. And the main high risk features are jaundice or a dilated pancreatic duct greater than 10 millimeters or an enhancing mural nodule. There are multiple other high risk features on imaging that then warranty of following up with an EUS, such as the cyst size greater than 3 centimeters, presence of pancreatitis due to the cyst. And this is essential when you have a patient with pancreatitis and a cyst, to know whether the chicken came first or the egg, and if the cyst is due to the pancreatitis or the cyst is the cause of the pancreatitis. And it's always good to go back and look at the prior imaging to see if the cyst was present before the pancreatitis attack set in. If the cyst has enhancing walls, or if the main duct is between 5 to 9 millimeters, elevated CA19-9, and lymphadenopathy, or whether there is a change in the cyst size. And this is a little new between the guidelines, whether it's greater than 5 millimeters over 2 years or greater than 3 millimeters per year, then these should be followed with an EUSFNA. And traditionally, with the USFNA, we check the cytology, the CEA, amylase, and I reviewed this in the prior slide. And a low CEA is seen in a pseudocyst or a cystadenoma. And you would see a high amylase in a pseudocyst. The pseudocyst is a low CEA, low amylase. In an IPMN, you would see a high CEA and a high amylase. And most of the studies use a cutoff of 192 for the CEA and 250 for the amylase. And for a mucinous cystic neoplasm, you would see a high CEA and a low amylase, because these do not communicate with the main duct. However, as I said earlier, 10 to 30% of combined clinical and cyst fluid investigations may yield equivocal results, and neither cytology nor CEA are perfect in deciding between a mucinous cyst versus a non-mucinous cyst. And there are other additional sampling strategies that we can use to further help characterize these cysts, such as the cyst fluid molecular analysis. The presence of KRAS or GNAS mutations have a high specificity for the diagnosis of mucinous cysts. However, their presence do not denote an increased cancer risk. So these can be costly, and but can be useful when the diagnosis is not clear based on US or cross-sectional imaging alone. You can use the microforceps. This goes through a 19 gauge needle, again has a high specificity, but you have to be careful. There is a risk of bleeding, but again, a large volume prospective studies are needed to further evaluate its safety and efficacy. Cyst endomicroscopy, where you advance a confocal laser endomicroscope probe through a 19 gauge needle, and you examine the cyst wall epithelium in real time to further assist in identifying the type of the pancreatic cystic lesion you are evaluating. And now cyst fluid glucose has gained a lot of popularity. Multiple studies have shown glucose levels to be lower in the mucinous cyst compared to non-mucinous cysts. A meta-analysis of 8 studies, including 609 pancreatic cystic neoplasms, found that when the cyst fluid glucose was compared with CEA levels, glucose had a higher sensitivity, 91% versus 56%, and diagnostic accuracy for detecting mucinous lesions. Again, this was 94% versus 85% with the CE alone, with no difference in specificity between the two tests. So when the pancreatic cysts do not have any of the previously discussed high-risk features, they enter into a surveillance program. And this slide summarizes the surveillance recommendations by the various guidelines based on the cyst size. And if it's a less than 1 centimeter cyst, the Fukuoka guidelines recommend a CT or MR in 6 months and then every 2 years. Whereas the ACG guidelines suggest MRI every 2 years and then lengthen thereafter. For 1 to 2 centimeter cyst, the Fukuoka guidelines recommend a CT and MRI in 6 months for the first year, and then yearly for 2 years, and then lengthen the interval if it's stable. The ACG guidelines recommend MRI every 1 year for 3 years, and then every 2 years for 4 years, and then to lengthen the interval. For 2 to 3 centimeter cysts, the EUS is recommended by the Fukuoka guidelines in 3 to 6 months, and then every year, and alternating MRI with the EUS as appropriate. The ACG guidelines are a little similar there, where it recommends an EUS or MR every 6 months for 3 years, and then yearly for 4 years, and then to lengthen the interval. For cysts greater than 3 centimeters, you could alternate MRI and EUS every 3 to 6 months as per the Fukuoka guidelines. And then, however, the main thing to consider is to refer to a multidisciplinary group, and make sure these patients are followed by an expert team. So, looking at the impact of the guidelines, Lobo et al. Developed a Monte Carlo model to evaluate the outcomes of a cohort of 10,000 patients managed per each guideline. And the primary outcome was mortality related to pancreatic cysts. And what they found with this model was that they looked at patients aged 55 to 70 years and assumed the rate of malignant transformation to be 0.12% per year. And what this model showed, that the two guidelines were similar in terms of deaths related to pancreatic cystic neoplasm management. Um, the 2017 international guidelines had more surgeries and more surgery related deaths, more imaging studies, and a higher total cost per cancer identified, which corresponds to about 3.6 million higher cost per additional cancer detected. However, the 2015 AGA guidelines had more missed cancers and more cancer related deaths. And finally, the model predicted that more overall deaths that were unrelated to pancreatic cystic management, and the more patients died from deaths that were unrelated to the pancreatic cyst. And that's they concluded that if the rate of malignant transformation of the pancreatic cyst is low, a less intensive guideline will result in similar deaths to a more intensive guideline at a much lower cost. And thus, now that we've looked at all the guidelines, we come back to our patient where we started off with. And based on all the imaging characteristics and the labs, what would be the next best step for our patient, whether we would consider an MRI in 3 months, an EUS, directly refer the patient for a Whipple surgery, or we would not recommend any further interventions given his comorbidities. And what we went ahead with was an EUS to further evaluate the findings of the MRI, because there was a little bit of discrepancy between what the MRI and the CT reported. And we did find a significantly dilated pancreatic duct, and in the head was this 4 centimeter cystic lesion with a solid component to it. And FNA was performed of that area under EUS guidance, which revealed atypical cells, and the patient was discussed at a multidisciplinary team. Again, this had a low CEA and a low amylase. So if you're thinking, this could be a main duct IPMN, it didn't have a high CEA. The patient was discussed at the tumor board, given his prior history of end-stage renal disease, prior history of lymphoma, and the confusion was, as I said, there was cytologic atypia. The CEA was low, but there was a solid component in a 4 centimeter cyst. And the final decision was that the patient would be referred to surgery. And he did undergo Whipple surgery, got clearance from the transplant team. And the final pathology did show and main duct IPMN with high grade dysplasia. And the patient actually did well after surgery. So the main take home points is find that balance between missing a cancer and over testing and over treating and your patient or over surveying the patient. Risk versus everything in medicine comes down to risk versus benefit. And the guidelines all vary a little bit, and they're here to help guide you, but you have to look at the patient overall. And not all the guidelines look at the patient's family history of cancer or genetic mutations, smoking, their underlying diabetes. So you have to look at all those factors and then apply the guidelines and see what's best for your patient. And if your patient is not a good surgical candidate, then the question looms is, is there a benefit to surveying? A less intensive strategy is recommended when there are no high risk or worrisome features. And if you have a healthy patient with high risk features such as a mural nodule, dilated PD, a positive cytology, then you work with a multidisciplinary team, evaluate them for surgery versus an intensive surveillance. And a multidisciplinary team approach is always key in managing these patients. Thank you very much.
Okay, thank you guys. We're going to invite actually any of the faculty that are here that want to come up to the stage. We're going to do a Q&A session. There's a platform for you guys to enter your Q&A into. But if you guys also want to just raise your hands and speak loudly, we can ask you as well. So we'll just get everyone to come up here for a few minutes, gather your thoughts, and then we'll ask whatever questions you guys have. Come on up. You too. Awesome. Sachin.
And
Might as well
whoever.
have all of you up here.
So while our faculty is coming up here, just wanted to thank our speakers for the morning for this great session. I know we'll have a few questions coming up in just a bit. So till we have them, any takers on questions? We're still waiting to get them online, but if anyone has any questions, please raise your hand. Yeah.
You have the mic. You want to go first?
I have a question. Go ahead.
Yeah, I just was intrigued by Mohammed's practice now of not using rows for sampling. Are you limiting that to all comers or specific cases? Can you just tell us a little bit more?
It's all comers now, and we perform 1,600 EUS between me and the all like our advanced endoscopists, and all of us we stopped using rows. It would have been very hard with the volume and the increase of the practice. It was good like a few years ago when you have one case every once in a while, but if you have a day full of EUSs, it's so hard. I wonder what Dr. Barron does.
Yeah. So as somebody who trained later in my career in EUS, it was easy for me to step back and say the rows doesn't really make a lot of sense to me. I mean, let me give you an example. If you're doing a colonoscopy and you see a mass in the colon, you don't say, okay, colon site path, let's see what we got. And I felt like with the development of the biopsy needles, if you have a needle, if you know you're in the lesion and you have a needle that can perform with a biopsy, you should be able to get reasonably the same. It's not always the same. I guess if I was going to reserve rows, it would be for something that's really subtle and you're not sure that you're in something. But for the average person, it's got to, everybody in the room, including the janitor, knows they have pancreatic cancer. There's a mass, they're 80 years old. It's big. I mean, I don't really think that it helps me that much. And it is a lot of time to have them come down, have them prepare the slides, do the slides. And as mentioned, it's a lot of time. We also did a study that unfortunately nobody seems to ever cite, where we actually, it was actually in a good journal, where we actually looked at that specifically as well. And in our institution, it didn't seem to help us to do on-site path. Let me just add one other thing, not to delay things. What I do if I have a patient then, so see, people may say, well, what if you want to change your strategy based on whether you know it's benign or malignant? So what I do, let's say I have pancreatic cancer, I'm pretty sure, even if I'm pretty sure clinically, I don't have a biopsy back, I won't put in an uncovered metal stent. I'll put in a covered metal stent. And while technically it's not designed for removability, we know we can remove. So you don't want to put in something that you can't remove. And let's say you find out that it turns out to be autoimmune pancreatitis and you thought it was cancer or it was lymphoma, which will melt away and you're stuck with a stent. So I've kind of done that. And that's a fallback if for some reason it doesn't come back as carcinoma.
Yeah, that was going to be my question for the centers that don't use rows. How do you approach those patients with obstructed jaundice and a pancreas head mass? Because even if it's not autoimmune pancreatitis, if it's metastatic lymphadenopathy from colorectal cancer or pancreatic neuroendocrine lesion, if you put in an uncovered stent, those patients may live 2 or 3 years, even if it is malignancy, and that could be problematic for them, especially if they're not surgical candidates. So is that pretty much the consensus for the panel here, that in those patients you put in a covered metal stent if you don't have rows or on-site cytopathology?
So I think there's twofold of the question. What happened if you have, how many patients you would have to bring back because you're not having pathologists? And we looked at that, and it's 6 in 100, so 6%. So we do have patients who will come back that they don't have enough biopsies, but there are very few with the FNB and having good pathologists, I think, and you can see the visible core. And now we can tell by looking at the core, if you can see the white tissue, and if you have enough of the white tissue, not red, you know that you have enough the sample. So we actually, each sample, we look at it. And you obtain samples so you feel it's comfortable. And if you have, obviously, if you are in a high volume center, I don't know if you can reproduce that everywhere, but it's only 6%. In terms of what we do, we only put fully covered metal stent. Not I don't know if other put uncovered, but I still use the practice of fully covered, and then you can remove them later on. But most of the time, if the patient have jaundice, pancreatic mass, and they are coming for EUS and FNA, you obtain the sample, you know it is cancer, you put the stent, and if later on this is autoimmune, which is extremely rare, you can always remove the stent later on.
Thank you. So I think, there's different opinions. I know there's a strong push now to not do rows, but I would just make a comment that it depends at your institution, your cytology support that you have. And, you'll have cytologists who with one pass, they'll just say, nope, I don't need anything more, you have it. And over the years, you can see that too, but there'll be a cytologist who might say, well, maybe I need 1 or 2 more, right? So it all depends on your institution. So I would just, think about this before just, making changes to your practice. But we are
University of Colorado should do this study. Like you guys should divide yourself, half do it with rows, half without rows, and see what would happen. I think it is a great study.
So Todd, you're not the only one whose study was not referenced, but we did a randomized control trial actually that compared EUS FNA with and without an on-site cytopathologist when I was at WashU during my advanced endoscopy training, and we got that study here. So we had endoscopists at Colorado and we had endoscopists at WashU, and you're spot on that having an on-site cytopathologist had really no impact on the overall diagnostic accuracy, adequacy, contamination, bloodiness, and all of that. And we actually followed those patients for a year, where we again demonstrated the same findings, that the accuracy was really no different between USFNA with or without an on-site cytopathologist. The problem is that we haven't been practicing what the RCT showed, because we still bring an on-site cytopathologist to confirm our diagnosis.
Now, I will make one counter argument beyond diagnostic accuracy, because those studies have been done. There is a service aspect of it as well. When that patient wakes up in recovery with on-site cytopathology, you can with a degree of confidence, be able to communicate to them the diagnosis and perhaps give them a general overview of what the expectations are and move forward with referrals right there on the spot. So that will be one perhaps counter argument to having that service, especially for patients with that present to you with obstructive jaundice from malignancy. So that's one other thing I don't think is really discussed with this argument.
Yeah. You have seen, I'm sure it doesn't happen often, but where they're fairly confident, but yet when it comes out the end, it's still non-diagnostic. So my counter to your counter is that you never guarantee them, right? And if you have somebody with a big mass that you do an FNB, you're still going to say you most likely have cancer, right? But I hear what you're saying. Rob Hawes says the same thing. He says we have patients that really want to know after the procedure and that sort of thing. But
So when I switched from rose to no rose, this was my main psychological barrier, in that what I'm going to tell the patient at the end. But now I got so comfortable telling them, I have experience looking at the lesion to give you a preliminary opinion, but you have to wait for 5 days to get the final answer. And I just tell them, describe what I saw by ultrasound.
right.
And I tell them this most likely cancer, but we will see, or I'm not sure. Let's wait for the results. If you set the expectation before the procedure that the results will come in 3 days, they accept it. But that was my main barrier when I switched. I didn't feel comfortable because of that. Yeah. Right.
Now, will you utilize Rose if you have a non-diagnostic sample and they're coming back? I guess that's one question I have. If you're doing a second EUSF&B in these patients.
Like using roses.
So you do the first procedure, it's non-diagnostic. They're now coming back for a second EUSF&A or FB procedure.
Yes. In this situation, I will ask them to come to the room. If I have a patient that failed biopsy, then there's something going on. I would plan it ahead of time and ask them to come. Yes.
All right, so with that, we're going to move to, I have a question for Dr. Easler and Dr. Othman and the others as well. So we heard about subepithelial lesions, and as you know, in our line of work, we see a lot of these lumps and bumps. And the standard teaching always is if it's asymptomatic, small in size, incidental, do nothing if it's benign and so on. But we all now have endoscopic techniques where we can remove these lesions. And so if you have a 45-year-old patient, otherwise healthy, with 40 years or more of either thinking about it or undergoing surveillance, what is your practice in these patients? That's one. And the second thing is, if you're considering resection, what's the role of FNB before? Does it scar down the submucosa? Does it affect stir and full thickness resection? So just wanted to get your thoughts.
Yeah, I think that's a good point, and we all struggle with that. The endoscopic burden of surveillance can be quite high in patients. I think there are a lot of variables that go into the decision making. First of all, what's the patient anxiety? You know, is this thing going to be something that's going to keep them awake at night? When they're, when you're planning surveillance intervals and they're coming back at a year and 3 years. I touched on this briefly. What other endoscopic surveillance studies are they going to have? Is this somebody with Barrett's? Are they coming back every 3 years to 3 to 5 years to biopsy their Barrett's? Because that's not an infrequent scenario where you encounter these patients. They get an upper endoscopy for their Barrett's and they've got a layer 4 lesion, in which case you can embed their surveillance in that setting. But if you have a young patient, the endoscopic surveillance burden is going to be high and the resection is going to be low risk, like it's maybe submucosal, and there seems to be a good margin between the lesion and layer 4. I think in it's small, there's a good argument to do something like EMR or even ESD, which is relatively low risk, to remove the lesion and graduate them. So I think there is a role for that there in the right patient. Patients that are older, and this has been watched for a little while, I think you can spread out the intervals and make an argument to keep with the surveillance strategy. So those are the variables that I'll consider in these patients. But I think you bring up a good point. Bore resection in a young patient, where the resection would be relatively low risk, and you can graduate them and spare them the endoscopic burden of surveillance. I'll see what other people have to say.
Yeah, I totally agree. If we think about colon polyps, I'm not going to see the polyp and say it's still small. Come back in 2 years till it grow enough for us to remove it. So I know that our guidelines doesn't talk about this for gastric subepithelial lesion, which is when they are smaller than 2 centimeter. And instead of doing surveillance, that's the easiest time that you can remove them by stir or by even full EFTR device. So when I do these cases, I go into algorithm. And algorithm has two factors in it. One factor is the size of the lesion, because if it's too large, that's going to go for surgery. I might need to biopsy it before surgical resection. If it is smaller than 2 centimeter or up to 3 centimeter, then I will look at the age and the characteristic of the lesion. And by EOS, if I think it will require removal, I don't do FNB. I will just remove it, because once you do FNB of the lesion, you cannot do the stir. It's so hard to go through this fibrotic area. So I would just do stir right away in the next session after I discuss it with the patient.
Just for the fellows, does everybody know what STIR is? No. Submucosal tunneling endoscopic resection. So it's third space to get in and do a resection. But the other thing is, some of these lesions, though, you don't have to completely remove. You really just need to get an established diagnosis. And you can perhaps do that sometimes better with resection, EMR, because if you find out it's really not anything you need to worry about, you can leave it behind. You know, the residual. In other words, you don't have to get a deep, complete resection on all of them. Right. And then you know that it's something that won't require, like he said, a leiomyoma, that wouldn't require a follow-up endoscopy. So even if you leave some residual behind.
I agree, and I think, Dr. Othman said it. I have the same philosophy that if you're planning on resecting this, I don't do an FNB. I've been burnt a couple of times where I started the tunnel, and once you get to the lesion, it is just impossible to separate the lesion from the overlying mucosa, and then you end up not being able to do what you could have done. And now there's a big question in the patient's mind about, whether this should be removed surgically and whether it's worth the risk. So I think this is an ongoing concept, but I just wanted to get the thought from our panelists. So I think Dr. Kothari has joined us via Zoom. Shivangi, can you hear us?
Yeah, I can hear you. Can you hear me?
We can. Hope you're feeling better.
Yeah, doing okay. Thank you.
Wonderful.
Okay, we have a question for you from the audience. What has been your experience with pancreatoscopy for the diagnosis of IPMN?
Yeah, so I routinely don't do pancreatoscopy for IPMN. I think between the MRIs and EUS, so we are able to get a diagnosis. However, usually if the surgeons do request in terms of surgical planning, I do perform in those cases, but not routinely for diagnosis. Again, you have to be mindful of the risk of pancreatitis, and the mucin usually in these cases is so thick that even if you put the pancreatoscope in to be able to suction and get a good vision is limited.
Thank you. What about the rest of the?
Yeah, I agree. We don't usually use it just for diagnostic, but as mentioned, for planning, just for the fellows with main duct IPMN, the entire duct can be dilated no matter where the lesion is, because mucin fills the entire duct. So if a surgeon wants to resect it, they need to know where the IPMN is located within the duct. And so if you do pancreatoscopy, you can basically map out and make sure that it's isolated to one area or another. That way they can plan the resection. So we use the same philosophy. We only do it or if the diagnosis we can't make any other way, then we'll do pancreatoscopy, but not routinely.
Great. I think our experience here is similar, and we recently did basically a study with our surgeons where we were all going intraoperatively to make sure that they had completed their resection margin. So doing the pancreatoscopy while they're in there to make sure they got everything.
Right.
Okay, great. Sort of a follow-up question to what we had before. In patients with associated obstructive jaundice, when performing a combined EUS ERCP after FNA, FNB, do you also perform biliary brushings or biopsies prior to placing a stent?
I'm
I-
assuming this is without Rose.
I've basically done away pretty much with cytology, other than, let's say, PFC patients.
Yeah.
But or maybe suspected cholangiocarcinomas, but for basic distal bile duct pancreatic cancer, we don't do it. I don't think the sensitivity, as you know, is so low, and your tissue yield is so high with FNB. I personally don't do it.
Anyone else?
So for pancreatic adenocarcinoma, no, I don't think we need it. But for mid CBD and up, then I do three things actually. I do the brushing and then direct biopsy. And while you are biopsying, the fluid that you irrigate with, if you suction it, we show that just collecting that fluid, you can increase the sensitivity up to 90%. So for all these indeterminate structure, using the irrigation fluid from the spyglass, from the cholangioscopy, it increased the yield because it has a lot of cells, especially after you did brushing and took the biopsy, because this will release more cells. And it's very cheap because you don't have to do anything, just collecting water and sending it for cytology.
All right, well, we have one more question coming up. Any thoughts about FNB with slow pull of the stylet technique?
Yes, well, I am very controversial today, and I'm sorry for that, because I feel like slow pull is perfect for FNA because you don't want to have blood. With FNB, honestly, you are taking tissue and you want a good suction with it. When we looked at initial experience with FNB, we were comparing full suction versus half suction, and we find that half suction yield the best result. So you don't have to go all the way to the end of the suction, half of the suction. Honestly, once I start doing FNB, I stopped doing the slow pull technique because I'm not doing FNA needle. So I really don't have experience with FNB with slow pull because I use suction.
We use slow pull for all of our FNBs with the caveat. So I do what he mentioned is I look at each sample. If you see white tissue, then you probably have a diagnosis. And if you're not, the only time I add suction is if for some reason we're doing good slow pull and we get minimal in the jar, then I'll add suction. But if we're getting what looks like good pieces, then I just go with slow pull. But
Yeah, our practice is very similar to what you said, but for the audience, I would say that as you can hear, there's a bunch
Yeah.
of different, styles, techniques, and views about doing
Yeah.
FNA, FNB.
Yeah. Again, for the fellows, slow pull, I don't know if is basically you take the stylet and as you're going in and out, your assistant is gradually pulling the stylet so that that's what gives you the negative suction to bring the tissue or the cells into the needle. So every FNA or FNB needle both come with a suction with it. So your choice is whether you use the suction or you just use the stylet as your slow pull. Sorry.
No, go ahead. So I think we'll go to the next question. I think this is for Dr. Kothari. What is your current practice on checking cyst glucose level during FNA? Is that routine for you?
So I do check the cyst glucose now, and but I have not done away with the CA amylase. I think I'm still caught in between. So, but I do check the cyst glucose, and we are looking at our data. There are studies saying because you need much lesser fluid to do the glucose test, that if you don't have enough fluid, then you could if there's just one test you can send for then to check the glucose. But I have added it onto my cyst profile, but that's not just exclusively glucose check.
Just a follow-up question. Are you sending that to your chemistry lab sort of along with the amylase level, the CEA, or are you doing sort of a bedside glucometer, which I know some people are doing?
Yeah, so and again, the meta-analysis that I quoted checked the fluid very different ways, and sometimes the glucometer may not be able to detect the glucose when it's really low and give you an actual number. So it is suggested that you send this to the lab, and they are all used to checking the body fluid glucose levels. So I send it with my fluid to the chemistry lab for testing.
Great. Anyone else from the panel want to add anything? No? Okay. It looks like we have one last question. For incidentally found firm appearing subepithelial lesions, do you recommend obtaining bite-on-bite biopsies? Does this have any impact on complete resection later on?
I don't do it. I think the yield is very low. And then as you heard from some of the other panelists, if you're planning for third space endoscopy techniques to remove it, it could probably be very problematic, I would think. So, but interested to hear. I don't do third space resection, so I'd be interested to hear what the other panelists have to say. But I think the yield's very, very low.
I get many referrals who the referring physician do that, and they do obtain diagnosis. So if you really continue to do bite on bite, you will get diagnosis, even just. But a lot of time too, you don't. So I would say it is not that perfect, and it also can cause bleeding. And once you have that, you will find the central depression above the lesion, and then I would end up doing full thickness resection of the entire area because no matter how small it is, you have severe fibrosis. But also, we don't have any data to say you shouldn't do this or you should do it because honestly, our research in the small subepithelial lesion is really lacking. We need to do a better job in characterizing this lesion and know what the best way to treat them.
All right.
Perfect. Anyone else have any questions that they didn't answer or ask over this forum that you want to raise your hands for? No, they look like we're good. Okay, awesome. Thank you guys. Great Q&A. Thank you for all your lectures. Let's take a break and see you back.